So why do we need to do multi-center studies? Because if there's one center, as Dr. Kim clearly pointed out, there's a big risk for bias, especially if you're a tertiary care center. So you only get the worst of the worst patients. Or if you're in a group in the part of the country where certain infections or diseases are endemic, then all you will see is that. So you can have a multi-center study that goes all the way from your center as the pinnacle down to your wedge-shaped to the people who are referring centers, or you can have several tertiary care centers so that you can see a broad spectrum of disease. So if the trends are the same throughout, then you'll be reasonably confident that this is really representative of your whole country, your region, or wherever you want to do this. And when it comes to rarer diseases, this is actually the norm. And things such as Valdig, which is the things of the portal hypertension, things are very rare diseases. Things for PBC, things for consortia for very rare complications. You need multi-center studies. Otherwise, this becomes very difficult. And what are the problems in this? So you can have the first set, the basic discoveries, clinical insight. Let me see if this works or not. Oh, nothing works. Oh, okay, it works like this. Good. Okay, this is even more. Okay, basic discoveries, clinical insights, implication for diagnosis and practice, and population health. So what we are doing is first figuring out this is not going to work. This is even worse. If you did T2 to T3 is where we want to go right now. T4 is the ideal situation. And between T2 and T3, you really want to get to as many centers as possible. And this is very doable, even at a junior stage, because I've seen a lot of people basically gathering together in meetings, even research fellows and fellows together, and they band together so that when they become attendings or when they actually do things, they actually already have a brotherhood or sisterhood or whatever you want to call it already there. And that's how you're supposed to work. And this is where things are. So, but how do you actually want to go about it? So, let's talk about cirrhosis trials, which we actually did. On the top is the usual approach, okay? Literature review, data from secondary analysis, and risk stratification. In the bottom is the database or registry. Of course, as I said, you can create a database in your own center, but it's best to have a database that has multiple other centers as well, because it allows for real-time data, stratification, severity of illness, and could have some daily risk assessments. So on the top, as you go to the patient population, heterogeneity, demographics, and comorbidity are much, much higher in the usual approach, whereas when you come to a database and registry that has many more people in it and many more centers, this actually becomes lower. So the more different kind of people you have, and they all say the same trend, then you're much more reasonably confident that this is really true. So the key questions. Is there a burning question or questions that cannot be answered by a single center? From painful personal experience, I can tell you, the journals do not give as to how many people you have. The question still needs to be novel, okay? If you have 10,000 patients and they all give you the same trends as prior studies of 2,000 or 1,000 patients have done, and it is not really a novel question, it will not get into a high-impact journal, or it may not even get into a journal at all, despite all the effort that you've put in. So the question still needs to be novel, or still needs to be unanswered in your population with implications. So it's just not enough to have enough numbers. Are there also other centers that are struggling with the same issue? So if you have a rare complication in this disease process, but you only have 3 or 4 people, but it's very hard to manage those 3 or 4 people, the best thing is to go on social media or go somewhere else or connect with people in meetings and say, are you having the same problem as well? Let's join together and see what worked for these patients and what not, and then you can publish. Can the data be collected easily? So there is a balance between what you ideally want and what people will actually end up doing. Because if you want 100 things and people only have time for 10 things, then choose the 10 most important things. Do not insist on all 100 things, because that will never happen and you'll get a fraction of the things you want. Last but not the least, is there funding involved? Are you going to pay people for the time, effort, and energy that they actually do to actually make this happen, or is it just going to rely on the kindness of strangers? And that becomes a big issue, because if someone says yes, but they cannot devote resources to do this, it will never happen. So many questions are there in cirrhosis and encephalopathy. There are many people who are struggling with the disease. The data depends on the design, and the funding obviously helps. So if you have money, it always greases the wheels, and it takes further. So NACSLD, the North American Consortium for Study of End-Stage Liver Disease, which Dr. Garcia Tsao and Dr. Reddy are also part of, was a figment of our imagination before. It was a little blob in our mind. We wanted to make sure that we had a group in the United States and Canada that would actually counter some of the research that was coming out of Europe and Asia to actually get a North American voice to the things. So the initial question, all those things that I asked you, what are the determinants in cirrhotic patients hospitalized with bacterial infections? And as I can tell you, bacterial infections are all local. So just because someone in Europe found something else or someone in Asia found something else, that does not mean it applies to your population. It is so local that your hospital will have a different profile of bacterial infections than the others. So it was important to see if across this gigantic continent, were there specific trends. So what was the time between initial discussion and first enrollment? 5 months. This is electric fast when it comes to a multi-center study, mostly because we were so motivated, because we realized that we were going to be way behind all the other continents if that happened, and that motivated us. It was fear. That's what it was. What was the current enrollment for the first one? 588 patients in 17 sites without funding. So that was spectacular because everyone was motivated. I had no money to give anyone. I barely had money to give myself. So we all were bound by something that was more of an issue for that. So that was a noble kind of situation. So these were the centers in the prior one, NACSLD 1. And what is the method collection? It was very low key. The protocol and data sheets were formulated through the SIG meeting, the ACLF SIG meetings, a special interest group. Basically, we went there and asked what questions you want to ask. Database was created at the VCU Medical Center, and there's a software that anyone can log through anywhere in the world and actually put that. It's called REDCap. It was approved by local ethics board. There was a debate whether to use people in retrospective chart studies versus to actually do a prospective study in which we actually got the patient's consent. Everyone voted for getting people's consent. And thankfully, that's a much stronger study design. It delays it by a few months, and some people say no, but that's fine. They want their right to say no to do the study. The database is monitored, and specific aspects for clinical questions are extracted, analyzed, and published. So the important thing is no one owns the entire database. Everyone is renting their data out to this database. So if someone has 100 patients in their database and they want to publish from that 100 patients, they are free to do so. But if they want to use the 588 patients that are present in there, it has to go through a committee, and only the statistician that is being paid through this study, that is a part of this study, will have access to the entire data. That makes sure that no one runs away with the entire loot. So you have access to your own data. You can do whatever you want with it. It's yours. Okay. But you do not have access to the entire data. The only person who does it is the statistician. So what you do is you send a proposal. I want to study XYZ from this database. The steering committee votes on it. If they think it's okay, goes to the statistician. The statistician extracts the data and sends you the data. He does not give you the individual patient information because that is not what we signed up for. That is not what the patient signed up for. They want aggregate, okay? And that's what the ethics board wants. So this is the data management. Depending on how much money you have, you can get as much or as little as possible. You can have a ragtag group of people, like we had one statistician and me. That was our data monitoring thing. And we relied a lot of other people. And there, you can also have other things. You can have the database monitoring center, but this is for very, very high-end studies. And this is usually for studies that are proven biorepository studies or studies that we have for multi-center international clinical trials. They require a data management center because every I needs to be dotted and every T needs to be crossed. So this is the REDCap database. On your left-hand side, you can see site ID, demographics, cirrhosis details, all the things we collected. This was the first NACSLD, which is 588 patients only, unfunded. And it can tell you in one fell swoop how many sites it can tell you all of this data. So this is what we collected. And this is what suppose our first publication was in second infections. And you can see it can tell you how many people had a second infection and how many didn't as part of this database. Okay. But there are many other databases. The previous studies that we have, another study that is going to get published in CGH, is about old people and hepatic encephalopathy. As we get older, we get tendency to get dementia, but we also get hepatic encephalopathy. So that was just an Excel sheet that I sent out to everywhere. You don't even need to do this. You send an Excel sheet, you define what the outcomes are. On top, easily define what the definitions are, and you send it to whoever wants to do. So the Excel sheet works just as fine, Microsoft Access works just as fine, but this is a little more complicated, and this was already available to us. So this was our first paper. Then there were plenty of other papers to follow, and remember, this is unfunded. This is no funding at all. And this is a lot of other papers that followed this, and more than 20 abstracts. The first author was different in almost our abstract. 9 oral presentations, 5 posters of distinction, and multiple publications here. Many, many publications. And again, if you see the publications, this is not North America, North America. This is all things that are questions that are important regardless of whether it's in North America, regardless of whether it's in Europe, regardless of wherever it is. The scientific question is still important. So previously we thought everyone just had one infection. But no, we have 2, 3, 4 infections in our patients. So we were the first to point that out. ACLF in infected patients with a very simple definition. Further infections, gender creatinine, delisting in patients with cirrhosis, with infections that Dr. Reddy spearheaded. This is very important for us to realize that the question still is king. And many more other things. So then what we did, because of this data, we went and applied for funding. And we got funding, not from the NIH, not from any other places, but from a pharmaceutical company who is interested in making albumin, which is sometimes used in ACLF. So we got funding. And now we were able to expand this to NAXL2. So NAXL1 was only infected patients. NAXL2 is every patient who comes in who agrees. So this was a lot of other things, and you followed them up for 90 days. And because we were giving people money, we could actually also do assessments of the samples, serum sample, urine sample, and stool samples in these patients, because we had money. When we didn't have money, even though we wanted to do it, we couldn't do it. So we chose the things we wanted to do when we didn't have money. So among the many things, readmissions, Karnofsky scale, encephalopathy and mortality, baseline creatinine, and many, many others. And this is also been done in many, many other places. Of course, there's Easel Cliff, which started this whole process, the Asia Association study for ACLF and critical illness. Galaxy is alcohol and microbiota biomarkers, Predict, MyEcoPredict, and Target and Checks, both regarding hepatitis C treatment practices. So these are things that are relatively easy to conceptualize. It's a little difficult to actually make into practice. And what are the lessons learned? Not everyone who will say yes will actually put in patients. But do not hold it against them. They have their own issues going on. But remember, the people who put in the 588 patients when it was unfunded were automatically in when the funding came through. Because you don't want someone who's a friend when you have money and is not a friend when you don't have money. Okay? It's very important to realize that in life and in research as well. So those people put their necks out, put their efforts out, and put in patients, did the work, got the results, but did the work. So they didn't even have to say they were automatically in because they did so much work. Then a balance between depth of questioning and ease of putting patients is required. Because you can want everything you want, but if only 10% of the data is filled out, then it is not going to be of any use. So this is why right now we are doing NAXL3, which is an outpatients. So we are right now fighting like cats and dogs about which question to put in and which not. Because if you don't ask a question now, you can't go back 10 years later and ask that patient a question again, especially when it comes to things like quality of life. So this needs to be happening. So sites have to be really committed, especially if funding is not available. And the last and the most important thing, you have to have a confidence in the overall goal to increase knowledge and have to have trust in each other. So if you do not trust the people who are in your consortium right now, that trust will not increase over time. If you do not trust the people who hold the keys to the database, do not participate, because that is going to cause a lot of drama later on, and that is not something you want. Again, these are not research-specific questions. This is life-specific questions. These are things that are very important. Okay. So what is my take? They are highly feasible, but again, need a coherent question. For example, like Dr. Ray Kim pointed out, diabetes and hepatitis C in Indonesia. Indonesia has so many islands, so many local practices, so many other things. It is even if you get like 3 or 4 island groups together, that in itself will cause a huge variation. And your population is huge. It's not like a small country. It's a huge population. And many of them are centered across these centers as well. So these are very low cost, low hanging fruit. Data collection tools need to be accessible. You can do Excel, Access, whatever. Amount of data required should have a balance between detail and practicality, and you need to have a focused strategy. Last but not the least, you need to have trust in your colleagues to put in good stuff, because garbage in is garbage out. So if you do not do the things to put in there before, it's going to be very problematic. So these are my acknowledgements to everyone who's the NAXL PI and coordinators, and thank you all for your time.